if the patient is uh, using the LABA or LAMA, okay, so LABA and LAMA, if the patient is using, so long-acting beta 2 agonist or long-acting muscarinic agonist like the tiotropium, okay, so you always advise for the LABA plus LAMA, okay, and if the patient is on the LABA plus ICS, okay, so ICS, and so if there's a 2 star, so consider de-escalation if the ICS or switch if pneumonia, inappropriate original indication or lack of response to ICS, you can go on that. Otherwise, if the patient is taking LABA plus ICS, you add both, okay, LABA plus LAMA plus ICS, okay, so and so this is how you are going to do if the patient has dyspnea. So if the patient has exacerbations, okay, so exacerbation is there, so if there's an increase in the symptoms of the patient, okay, so sorry, yeah, so if the patient on the LAVA or LAMA, then you can go with a LAVA plus LAMA combination or LAVA plus ICS, and again go with a consider if the patient has a eosinophil of more than 10 of the 100, then you use the LAVA plus LAMA plus ICS. Okay, so this is the mainly a thing that you are going to do, and then the triple therapy that you are going to do, and then the use the if the patient is not being controlled. So if the patient can you can consider with the roflumast if FEV1 is less than 50% and the history of chronic bronchitis in the case of non-smoker, okay, smokers. Okay, so you can use this. If the patient is an ex-smoker, then you can use for the azithromycin. So azithromycin as a immunomodulator. So this is how you are going to step up the treatment. Okay, so with on the regular follow-up. So this is how you are going to do it. Then what are the other non-pharmacological management of COPD? So in the patient with a group A, so then you go for the smoking cessation. Okay, so can induce include pharmacological treatment. Physical activity is mainly recommended. Okay, and flu vaccination, pneumococcal vaccination, pertussis vaccination, and for B, C, and D, you can go for smoking cessation. It should be there, and the pulmonary rehabilitation. Okay, so pulmonary exercises that we are going to tell to the patient, and as a physical activity always should be advised, and then the vaccinations. Okay, so vaccination in every step that you are going to use. So follow up. So this is the same thing that you are going to do. Okay, so the same thing. So what is the ideal use of prescription of supplemental oxygen to the COPD patient? So what is the COPD patient that you are going to use is mainly a arterial. Okay. Mm. So what is the indication of giving the supplemental oxygen to COPD or the patient who should be required the domiciliary oxygen is that if the patient has a, if you do the partial pressure of oxygen in the AVG is less than 55, or SpO2 saturation on the oximetry is pulse oximetry is less than 88%. So that's the record. Or PO2 is more than 55 and less than 60 mmHg with right heart failure, or there is a polycythemia. Okay, so this is the mainly a thing. And then the patient will require the supplemental oxygen. So that's the indication of giving the domiciliary oxygen. Prescribe supplemental oxygen and titrate to keep the SpO2 of more than 90%, and recheck in 60 to 90 days to assess if the supplemental oxygen is still indicated or not, if prescribed the supplemental oxygen is effective or not. Okay, so that's how you are going to for the domiciliary long-term oxygen therapy. So this is the indication of long-term oxygen therapy in case of COPD patient. Then what are the other surgical or interventional thing that has been available for the advanced COPD? So if there's an emphysema, predominantly phenotype with severe hyperinflation, if there is a large bulla is there, so only the one bulla is there, you can advise for go for the surgical removal of that bulla, that is bullectomy. And if there's a heterogeneous emphysema, no collateral ventilation, you can go for long volume reduction surgery or endobronchial valves, okay, bronchoscopic lung volume reduction, and you can go for endobronchial valves for that. Okay, so these are the things. If the collateral ventilation is there, you can go for lung volume reduction surgery and bronchoscopic lung volume reduction surgeries that you can do on that if there is no large bulla. Okay, so large bulla and emergency emphysema. So all these are the things that you are going to do is a BLVR, okay, bronchoscopy lung volume reduction procedures that you are going to do. And then if there's no is not a candidate for bulectomy, there's no candidate for bronchoscopic volume reduction or lung volume reduction surgery, so that patient is a candidate for lung transplant. Okay, so that's how you are going. So the available thing is bulectomy that you can do. You can do for the lung volume reduction surgery, or bronchoscopic lung volume reduction that you can do with the endobronchial valve and all these things. Okay, and then lung volume reduction coil. Okay, and then the paper ablation. So PA means paper ablation, and the last is the resort is a lung transplantation. So what are the potential indication for the hospitalization of the patient with the COPD? If there is a severe symptoms such as sudden worsening of the resting dyspnea is there, high respiratory rate, decreased oxygen saturation, confusion and drowsiness is there, patient is with the acute respiratory failure, patient with the onset of the new physical signs like cyanosis and peripheral edema, so that the patient is going to heart failure. Okay, and then the failure of an exacerbation to respond to the initial medical management, so that's the requirement of the hospitalization. And the presence of serious comorbidities like heart failure, newly occurring arrhythmias like atrial fibrillation or any arrhythmias. Okay, and insufficient home support. So these are the ideal indications for admitting the patient to the hospital. So what is the complications? So what are the complications? So this is the important question that will be asked to you. What are the complications of COPD? So patient can present with the acute exacerbation of COPD. So I'm going to deal with the acute exacerbation of COPD in the coming slide. So then the pneumothorax because of the rupture of the bulla. Okay, and then the patient will have a secondary polycythemia. Patient can have a pulmonary arterial hypertension because of the hypoxia, leading into a increase in the okay, endothelial hyperplasia of the pulmonary artery, leading into pulmonary arterial hypertension, and that ultimately lead into the dilatation of right ventricular hypertrophy and the right atrium, leading into chronic call pulmonale. Okay, so call pulmonale, and then the respiratory failure will be there. The so this osteoporosis. Okay, so this spelling is mistake. Osteoporosis, and then the patient can have a high chance of having developing a drip vein thrombosis because this patient has and the high risk of having a secondary polycythemia. This also leads into high risk of having deep vein thrombosis, and patient is mainly a bed bound. Okay, so immobilized, so then patient has a high chance of having a deep vein thrombosis leading into pulmonary thromboembolism. So these are the most important complications of the patient with chronic obstructive pulmonary disease. So coming to the exacerbation. So what is exacerbation? So exacerbation is defined as an acute worsening of the respiratory system that result in the additional therapy. Okay, so what are the worsening of respiratory symptoms that I'll come in the coming slide. Okay, so coming slide. So so defining the exacerbation or classifying the exacerbation. So as already in the ABCD module I told you is as a moderate and severe exacerbation, we'll give a more point. So what is mild? So if only the patient is requiring short-acting bronchodilators on and off, so it is a mild exacerbation. And moderate if it is treated with a short-acting bronchodilator plus antibiotics and patient requires the oral corticosteroids, that's the moderate. And severe is the patient requires the hospitalization or has to visit emergency room visit. So then this is the severe exacerbations. Okay, so this is how you can classify the type of exacerbation as into mild, moderate, and severe. So what is the worsening symptoms? What are the three symptoms that you have to consider to say this as an acute exacerbation? So in the history, if you are finding that patient is telling that so my cough has increased than the previous days, so this is the one that symptom has increased, and the another symptom that has increased is the increased breathlessness. Okay, so previously the patient is all right, sitting comfortably, and now this breathlessness has increased. So then there's another point that you have considered, that the worsening of symptoms. And the another two things is that increase sputum production, and the another one is the change in the sputum color. Okay, so the previously the sputum is white, now it has changed into purulent or greenish, then you think that it has the worsening of symptoms to say this as the acute exacerbation of the COPD. So what is the causes of exacerbation? So it can be if the patient is exposed to more the new pollutants. If the patient has a infection with a virus, so it might be any virus. Okay, so adenovirus or rhinovirus or influenza, or now is a COVID. Okay, so COVID, and then the bacterial infections. Okay, so, and that's result into the inflamed COPD airways, leading to increased airflow limitations, and this ultimately leading to dynamic hyperinflation, leading into exacerbation symptoms. Okay, so this is how the pathways goes on for the exacerbation. So how will you manage the exacerbation? So management of exacerbation but which is not life-threatening exercise. So you can assess the severity of the symptoms. You do the atrial blood gas, whether there's a respiratory failure or not. You do the chest radiograph to see whether there's a pneumonia or not, whether there's a pneumothorax or not. Okay, so all these things that are going to you do in the emergency, and then administer the supplemental oxygen therapy. So the oxygen therapy should not be the high flow oxygen, because in the COPD always there is a hypoxic respiratory drive. So if you treat the hypoxia, then the patient will go land up into respiratory arrest. Okay, so that's why you have to give the low flow oxygen in case of COPD patient. That should be kept in mind. So obtain serial atrial blood gas, venous blood gas, and the and the pulse oximetry measurements. So you give the bronchodilators, increase the dose or frequency of short-acting bronchodilators in the form of salbutamol, and then you can also add on anticholinergics. Okay, so anticholinergics like ipratropium bromide. Consider use of long-active bronchodilators when the patient becomes stable. So use spacer or air-driven nebulizers when appropriate. Okay, so it's better to give the nebulizers or spacers you can use, and consider using the oral steroids. If the patient is able to take the oral steroids, use the oral steroids in the form of prednisolone, or you can use the, okay, if the patient is not able to take oral steroids, then you can consider for using the hydrocortisone injectable, or you can use the methylprednisolone. Okay, so and consider the antibiotics. So you can use the oral if the patient is taking, okay, orally, or you can use the injectables if the patient is not taking orally. And consider non-invasive mechanical ventilation. Okay, so non-invasive ventilation in the form of the BiPAP. And then at all times monitor fluid balance. Consider subcutaneous heparin or low molecular heparin as a thromboembolism prophylaxis in the every admitted patient. Identify and treat the associated conditions like heart failure. If there's arrhythmias, there is a pulmonary embolism is there or not. So if it is there, you have to consider the treatment of heart failure, arrhythmias, and the pulmonary embolism in the form of anticoagulant. Okay, so anticoagulation. So key point for the management of exacerbation: short-acting beta-2 agonist is the you have to use. Systemic corticosteroids can improve the lung function, oxygenation, and shorten the recovery time and hospital duration. And duration of therapy should not be more than 5 to 7 days. Antibiotics, when indicated, can shorten the recovery time. Okay, so for the antibiotics, so the most of the antibiotics which you use is the penicillin group of drugs like amoxiclavulinic acid, and the third generation cephalosporins like ceftriaxone, and then the macrolides. Okay, so macrolides in the form of azithromycin. Okay, so that you are going to use, because these antibiotics which you are using is to cover the most common organisms causing the exacerbations like H. influenzae, Streptococcus pneumoniae, Moraxella catarrhalis, and then the Chlamydia trachomaitosis. Okay, so these are the organisms which is mainly responsible for the acute exacerbation of COPD, the bacterial one. And the methylxanthines are ideally not recommended. So it has increased side effect profiles. But when the patient is not controlled, then we can consider for the methylxanthines. And the another is, if the patient in the respiratory failure, you use the non-invasive mechanical ventilation in the form of BiPAP. And if the patient is conscious, then you can use the non-invasive ventilation. And if it is not improved with non-invasive ventilation, then you have to go for the intubation into a mechanical ventilation in the ventilator. So what is the indications for the respiratory or medical intensive care admission for the COPD? So if the patient has a severe dyspnea that responds inadequately to the initial emergency therapy, so there is change in mental status, patient is a confusion, lethargy, and coma, then in that condition you have to transfer the patient to ICU. Persistent or worsening hypoxemia if the PO2 is less than 40, and or severe worsening respiratory acidosis and the pH is less than 7.25 despite the supplemental oxygen and non-invasive ventilation, and need for the invasive medical ventilation. Okay, so if the patient requires the invasive mechanical ventilation, in that case you can to shift the patient. Otherwise you can use the non-invasive ventilation even in the wards. Okay, so and the patient has a hemodynamic instability and patient need the iron drop support or pressure pressures. In that conditions, that you can send to the patient to the intensive care unit. So what is the indication for non-invasive mechanical ventilation in the patient? So at least one of the following: if there is a patient with the respiratory acidosis, if the pH is less than 7.35 and PaCO2 is more than 45 mmHg. So in that case, you can use the non-invasive ventilation. Severe dyspnea with clinical signs suggestive of respiratory muscle fatigue. Okay, so if the fatigue is there and the increased work of breathing is there, or both, such as the use of respiratory accessory muscles, paradoxical motion of the abdomen, or retraction of the intercostal spaces, in that case you can use, or persistent hypoxia despite supplemental oxygen therapy. In that case, you can use the non-invasive mechanical ventilation. So these are the indications for using the non-invasive ventilation in case of COPD. So indication of invasive mechanical ventilation. So patient who are not and unable to tolerate the non-invasive ventilation or non-NYV failure. If there is a status post respiratory or cardiac arrest is there, diminished consciousness is there. Okay, so and massive aspiration is there, or persistent pumping. So in non-invasive ventilation you are giving only the pressure. Okay, so if the patient has the aspiration, that will not come out, and if the patient has a vomiting, so that will again the high chance of having the aspiration. So in that condition you have to go for the ventilation. And severe hemodynamic instability without response to the fluids. Okay, so patient requiring the iron drops, and patient having a severe ventricular or supraventricular arrhythmias. Okay, so in that case you have to go for the invasive ventilation. And life-threatening hypoxemia in the patient with unable to tolerate NIV. In that case you go for the invasive mechanical ventilation, that you are going to put the patient into mechanical ventilators. So, so intervention that reduce the frequency of COPD exception is mainly a combination of therapies, so that you can use. And so vaccination is always advisable, and then the mucoregulators like mucolytics that you can use, and the all is the smoking cessation, rehabilitation, lung volume reduction, and now even the vitamin D deficiency is the risk factor of the exacerbation. So you have to add on vitamin D if it is required. Okay, so it's vitamin D supplementation. So common risk factors for development of the lung cancer in the patient of COPD is that if the patient has age of more than 55, smoking history, more than 30 pax years, presence of emphysema by CT scan, presence of airflow limitation is there, BMI less than 25, and the family history of lung cancer. So these are the common risk factor of developing lung cancer in the background of COPD. Okay, so COPD, so that can be also be considered. So with this, so I am concluding the today's lecture of COPD. So it's better you should follow the gold guidelines. Okay, so most likely, so in the new edition, so all these recent advances of these guidelines will be incorporated in the new edition of Davidson. So the previous Davidson has the old guidelines, old guidelines. So you can follow the GOLD Gold 2020 guidelines. Okay, so you can type it in the Google and then take it out from there also. And in new edition, whenever you are going for in your final examination, so the new edition that can be incorporated. So you read the Davidson for okay, this COPD. So all these are given in that. And the one slide that I have forgot to put is the prognostication of the COPD. Okay, so patient will ask, what about the prognosis of my disease? Okay, so for the prognosis there is a certain score that you are use, is a Bode index, BOD, Bode index. So that is given in your book. So B stands for breathlessness, O for airflow obstruction, and D for dyspnea scale, that is MMRC, and E for exercise tolerance, that is 6-minute walk test. Okay, so according to that they have given the certain points, and if according to that point the prognosis of and the mortality of the patient can be defined of the COPD. So how much like a year that patient can survive. Okay, so that's the Bode index, that is for the prognostication that can use. So with this, so I'm okay, concluding the today's lecture. So the next lecture, so that will go with another airway disease, that is a bronchiectasis. So, so if there is any questions that you can ask, case how. So basically, so this is the one of the important topic in respiratory. So you basically you read this. Okay, so read this. If there is any confusion, anything, you can Viber me out. Okay, so Viber me out anytime. So if there's no any question, then I can conclude it. Okay. Case question.